Hi everybody. Today we'll be discussing about radiolucent jaw lesions part 3. In part 1 and 2 we have discussed about odontogenic and non-odontogenic cystic lesions. Now we are discussing about non-odontogenic solid lesions. So in this we'll be discussing about central giant cell granuloma, intraosseous venous malformation and LCH. These are all radiolucent jaw lesions which are non-odontogenic and solid. Coming to first, central giant cell granuloma. So what is this? It is a reactive process secondary to hemorrhage within the mandible. So it occurs in younger women in second to third decade of life and anterior jaw, that is anterior mandible. It can also involve the maxilla. Mandible more than maxilla. And it is multilocular radiolucent lesion. They have a tendency to cross the midline. It's expansile with cortical thinning and remodeling. Internal septations giving rise to an honeycomb appearance. When the lesion enlarges in size, it causes displacement, resorption of the teeth, and with uneven growth, we have scalloped borders. On CT, obviously, bone involvement and cortical thinning is better seen. On MRI, on T1 and T2, it shows an intermediate signal and contrast shows a marked enhancement. So it's a multilocular radiolucent lesion. So anterior jaw is mostly involved, and this is about central giant cell granuloma. Coming to intraosseous venous malformations. So in the jaw. So this is also, it occurs in women second to fifth decade of life. Body of the mandible is most commonly involved, and the involved bone it enlarges. The developing teeth they erupt earlier. The mandibular canal and the mental foramen get enlarged. Adjacent teeth gets displaced as well as resorbed. So how? It presents like an unilocular cyst or cyst with ill-defined borders or sclerotic rim, or it can appear as a multilocular lesion, expansile lesion with honeycomb appearance. Why there is honeycomb appearance? It is due to resulting from fine trabeculae within the lesion, or it can be multilocular with sunburst appearance due to radiating bony spicules, or it gives a soap bubble appearance or tennis racket appearance in an expansile lesion with septations. So there are different presentations for it. It can give an honeycomb appearance, sunburst appearance, soap bubble appearance, or tennis racket appearance. So each one has its own differential diagnosis. Tennis racket appearance, differential diagnosis odontogenic myxoma. Sunburst appearance, osteosarcoma. Sunburst appearance, they form a normally in this the bony spicules, they form at right angles to the bone with surrounding intact bone. So in MRI there is contrast enhancement of this. And in multilocular, the loculations have fine fibular pattern. So, and most important thing about intraosseous venous malformations, directly we should not do biopsy. Before biopsy, needle aspiration should precede biopsy, then suspicion is raised. So this is about intraosseous venous malformation. Coming to LCH, Langerhans cell histiocytosis. So it has three types of presentation. It can be unifocal or localized form. It can be multifocal, unisystem or chronic recurrent form, or it can be multifocal, multisystem or fulminant form. Most common is unifocal or localized form. Mostly it occurs in 5 to 15 years of age, unifocal or localized form, and it involves single or few bones, may also involve the lung. Coming to multifocal, unisystem or chronic recurrent form, it occurs in 20% cases. They have this form. It involves multiple bones, liver, spleen, lymph nodes. Age group is 1 to 5 years. Coming to multifocal, multisystem or fulminant form, 10% of them present like this. It occurs in the first 2 years of life. It has a widespread involvement of the reticuloendothelial system. The other organs, normally LCH involves the skull, and here mandible is the second most common bone to be involved after the skull. So it can be unifocal, multifocal, unisystem or multifocal, multisystem. So presentation coming to, it appears as a light thick lesion with ill-defined borders in early stages or well-defined or sclerotic margins in the late phase. Ill-defined borders in early stages with sclerotic margin in the late phase. So there will be a cortical breach, there will be a periosteal reaction, alveolar crust involvement leading to scooped out appearance, alveolar bone destruction leading to floating teeth appearance. So there are two appearances. When the alveolar bone is involved, there is floating teeth appearance. When the alveolar crust is involved, there is scooped out appearance. See, on MRI, T1 will be hypo, T2 will be hyper, there will be contrast enhancement. Soft tissue extensions are better seen on MRI, and DD is osteosarcoma and malignant lesions. And look at the DWI. The ADC values are slightly higher in LCS than malignant lesions. So these are about the non-odontogenic solid tumors. So now we'll be discussing about radiolucent lesions with ill-defined margins. Whatever we discussed before, the radiolucent lesions with well-defined margins, they are odontogenic, non-odontogenic, cystic and solid. So now coming to radiolucent lesions with ill-defined margins, coming to malignant odontogenic tumors. There can be a carcinoma, carcinosarcoma, sarcomas. In carcinoma, there are ameloblastic carcinoma, primary intraosseous carcinoma not otherwise specified, sclerosing odontogenic carcinoma, clear cell odontogenic carcinoma, ghost cell odontogenic carcinoma. This malignant odontogenic tumors, the age group will be like between 6 to 8 decades. Presentation will be like irregular, ill-defined radiolucent lesions. So what are the aggressive features pointing out towards malignancy? Ill-defined margins, cortical destruction, soft tissue extension. The lesion has an ill-defined margin with cortical destruction. They go into the adjacent soft tissues with solid enhancing component which shows diffusion restriction. These are all the points point towards malignancy. Thank you.